Sir, shall we start the session?
Yes, sir. I am ready. Speaker is there.
Just check, sir.
Jijo, എന്നോടൊന്ന് പറഞ്ഞു ചോദിക്കേ. ജിജോയുടെ അടുത്ത് സ്പീക്കറിന്റെ പേര് ഞാൻ കാണുന്നില്ല, അതുകൊണ്ടാണ് ചോദിച്ചത്.
Shankar sir, are we audible?
Yes, yes.
Okay, sir. Shall we start the meeting, sir?
Yes, yes.
Okay, sir.
Only thing is Ananda Lakshmi on the host agane. Screen share here. Ananda Lakshmi.
One second, sir. Ananda Lakshmi sir join ചെയ്തിട്ടുണ്ടോ? Ananda Lakshmi Pediatrics.
Ananda Lakshmi ഉണ്ട്.
Co-host ആക്കി.
Co-host ആക്കി.
Sure. Good evening, everyone. We know it's been a late evening, but we are sure we are happy to have a good participant number even in the beginning of the program. As we are late in starting, we'll directly go ahead with the program. I would like to invite Dr. Arun Maman, the IAP Pathanamthitta President, to welcome the gathering. Over to you, Dr. Arun.
Thank you, Dr. Jijo. Respected State President of IAP Kerala, Dr. Joe sir, then guest speaker of the day, Dr. Anil Martin Das, who is the head of the Pediatric Metabolic Medicine, Hanover Medical School, Germany. The moderator of the session, Dr. Shankar sir, who is the professor at the Department of Pediatrics, SAT Hospital, Trivandrum. The Dr. Ananda Lakshmi, who is the junior resident at the Department of Pediatrics, SAT Hospital, and Dr. Goldie, who is the secretary of IAP Pathanamthitta, and other distinguished guests and senior leaders of IAP Kerala who have joined this meeting. A very welcome to one and all. Today, we have got an excellent session as a CME for today. That the topic is functional biochemical testing in the era of genomics. And we got an eminent speaker who has got immense experience in this field. I know that we have started the session a bit late, so I will not take much of your time. I once again welcome all to this session. Thank you.
Thank you, Arun. Without any further ado, we'll move ahead with the session. As we are moving ahead with the session, Shankar sir needs no introduction. Anibdar sir is a very senior pediatrician and he's been heading the IEM department. He's come all the way from Germany and he's currently with us in Believers for a day. And we are very delighted to host sir with IAP Pathanamthitta and the rest of IAP Kerala. And I'm sure others will join us from across the country also for this talk. I'll be sharing the screen so that sir can start his session. If there are any issues with the video or audio, do let us know. Is the screen visible?
Yes.
Yes, yes, Jijo.
Okay, I'll pass the system to sir to start off with the session. Over to you, sir.
Hello, good evening. Thank you for the kind introduction. So I will today talk about diagnosing of inborn errors of metabolism, which is a rather complex field. We have nowadays more than 1,000 different inborn errors of metabolism. Every year, new inborn errors of metabolism are identified. So in metabolism, substrates are metabolized to products, and this is catalyzed by enzymes. or alternatively, which you can see on the right side, substrates are transported from one cell compartment to another cell compartment across a membrane, and this is facilitated by transporters. More than 100 years ago, it was Sir Archibald Garrett who described the first inborn error of metabolism. This was alkaptonuria, a disorder in tyrosine degradation leading to the accumulation of homogentisic acid. In inborn errors of metabolism, there's either an enzyme defect, which leads to the accumulation of the substrate, which you can see on the left side. On the other hand, the product of the defective enzyme is reduced, and the accumulation of the substrate leads to the clinical symptoms. And this can also be used for making the diagnosis of inborn errors of metabolism. On the other hand, which is shown on the right side, there are transporter defects which lead to the accumulation of a substrate in one cell compartment and to a lesser amount of substrate in another cell compartment. The transporter defects are mostly the so-called storage disorders, lysosomal storage disorders like mucopolysaccharidosis or Fabry disease. And it takes some time until enough substrate accumulates in one cell compartment, leading then to the clinical symptoms. And as you can imagine, this takes some time. So these disorders are not acute decompensations, but they are chronic diseases, which are chronic cause. On the other hand, we have the enzyme defects, which lead to the accumulation of substrate, and this can happen really fast within hours. And leads to the self-intoxication of the patients triggered by catabolism. On the other hand, we have disorders of energy metabolism, cellular energy depletion manifesting as multisystemic disorders, as every cell needs energy to function. And these are the so-called mitochondriopathies or respiratory chain defects. The first days of life are critical for children with intoxication type, inborn errors of metabolism. This is due to the initial catabolism. As you know, every child is catabolic in the first few days of life due to insufficient breast milk production if the child is breastfed, or insufficient suckling, also with the formula diet. And this leads to self-intoxication, auto-intoxication of these patients. The trigger for metabolic crisis is, as I mentioned, catabolism, and this can occur in the postnatal phase, but also during later life in infectious episodes with a peak of 6 to 12 months of age. You have catabolism, which leads to an increased or a decreased caloric supply and a high caloric need. And in these situations, the body relies on the endogenous sources, on the endogenous reserves. So they metabolize amino acids, fatty acids, and carbohydrates in an uncontrolled fashion from the endogenous stores, which is not a problem for those children without an inborn error of metabolism. But for those having an enzyme defect, it leads to the accumulation of all the substrates proximal to the deficient enzyme. These are often toxic catabolites, toxic metabolites, and this then leads to the self-intoxication with clinical symptoms. In some countries, like in Germany, we have a newborn screening as a preventive measure. This is done nationwide on the second day of life. I'm aware that in India, that's not done nationwide, but there are some local initiatives and local screening programs, depending on the government and also depending on funding. This is Professor Guthrie, who in 1961 developed a so-called Guthrie test. It was a bacterial inhibition test to screen for phenylketonuria. The medium for the bacteria was devoid of phenylalanine, and then the blood was added. And the bacteria couldn't grow because no phenylalanine was in the medium. But if you add blood with high phenylalanine content, bacteria start growing, which you can see here on the plate. And this was taken as an indication that the child has high levels of phenylalanine or phenylketonuria. As you can imagine, this test was not very reliable, not very sensitive and specific. The children mustn't be treated with antibiotics, otherwise this test wouldn't work. Nowadays, we rely more on biochemical methods. A high throughput technology is a tandem mass spectrometry. In our center, this is done 6 days a week. On Sundays, no mail arrives, and so it doesn't make sense to run this test. So first, what you can see on the left-hand side, the blood is punched out of the filter cards. Sorry. And then it's analyzed, which you can see on the right side with the tandem MS device, and you can analyze more than 100 substances within 1 minute. So it's a high throughput technology. The principal amino acids, free carnitines and acylcarnitines are metabolized to butyl esters. They are injected into an ionic source, and they go into a first mass spectrometer and are separated. Then we have a collision cell where the ions collide with inert gases and are split into characteristic split products, and these are separated in a second mass spectrometer, and then you get a panel of different peaks and different compounds. These are the target diseases of the German newborn screening program at the moment. So we have biotinidase deficiency, classical galactosemia, amino acid disorders like PKU, phenylketonuria, and MSUD, maple syrup urine disease, or hepatorenal tyrosinemia, HT1. Then the fatty acid oxidation defects, the most common one in Germany is medium chain acyl-CoA dehydrogenase, MCAT deficiency. The long chain fatty acid disorders are less frequent. Then we have the carnitine cycle defects. We screen for CPT1, CPT2, and the translocase deficiency, which are needed to transport long-chain fatty acids across the inner mitochondrial membrane into the mitochondria for beta oxidation. And then we have organic acidurias, glutaric aciduria, and isovaleric acidemia. Then we have 2 endocrinological disorders, hyperthyroidism and adrenogenital syndrome, and immunological disease, SCID, and as a newer addition, 5Q-associated spinal muscular atrophy, SMA, where there's now therapy available, and sickle cell anemia and cystic fibrosis. The timing of blood sampling for the newborn screening is at 36 hours of life, and most of the children are then diagnosed pre-symptomatically. It may be that the child has some symptoms, some early symptoms when the result of the pathological newborn screening arrives, but this is still an asset. Then you can immediately start a specific therapy to prevent further deterioration of the child. In all other metabolic disorders, there has to be a clinical suspicion or a suspicious history. And based on this clinical suspicion, selective metabolic screening is performed. When should I consider an inborn error of metabolism? So there are certain laboratory parameters like hypoglycemia.
ఇప్పుడు మీ పిల్లోడికి నిన్న సాయంత్రం
Okay, so hypoglycemia, which is not explained by other disorders, metabolic acidosis with increased anion gap, metabolic alkalosis, decreased urea in blood, not only elevated urea levels are pathological, but also low urea levels. For example, in urea cycle defects, you have low urea levels. And hyperammonemia is a clue towards urea cycle defects, lactic acidosis, which cannot be explained by hypoxia or ischemia, could point towards an inborn error of metabolism. Then there are some clinical symptoms. Sometimes the children have symptoms of septicemia, but the infection parameters in the lab are negative. So this is highly suspicious of an inborn error of metabolism. Children can present with encephalopathy of unknown cause like coma and epilepsy. Acute liver failure, hepatopathy of unknown cause is a first presentation in some children. Cardiomyopathy of unknown cause, multisystemic disease especially. As I mentioned, there are toxic compounds which are in the organism and in the body, and they can reach different organs and lead to multisystemic disease. If there's aversion against certain food like fruits or protein or juices, then this may point towards an inborn error of metabolism. For example, if the children do not like fruits or fruit juices, this may be a clue towards hereditary fructose intolerance. A peculiar body odor may also be a hint for an inborn error of metabolism, and hyperventilation is often a symptom when ammonia levels are increased. So, for example, in lysosomal storage disorders, you see these patients with coarse facies, the peculiar hair, and on the lower right side picture, you can see some skin abnormalities, some depositions in the skin. This is a gentleman who was diagnosed with mucopolysaccharidosis. And in the beginning, this was thought to be hyperlipidemia, but lipid values in his blood were completely normal. And then further metabolic workup occurred. You have typical eye anomalies in Fabry disease, so-called cornea verticillata in the eye of Fabry patients. So sometimes we get referred Fabry patients from the ophthalmologist. And also the Fabry cataract is a symptom. Here you can see the angiokeratoma in Fabry disease can be quite subtle, as you can see on the right side. But on the other hand, there are also some very obvious changes on the skin. This is a young lady with icaptonuria. You can see that the sclerae are a bit grayish in color, and this is due to icaptonuria, where homogentic acid is elevated, and this leads to the discoloration of the sclera, also of other parts of the body, for example, the cartilage and also the bone. What are the methods to diagnose inborn errors of metabolism? So you can do laboratory assays at the level of metabolites, so-called biomarkers, which is most common and the easiest thing to do. You can analyze enzymes and add cofactors and see if the enzymatic activity changes. This can be done in blood cells, but also in tissue. If it's done in tissue, you of course have to take a tissue biopsy, and which becomes more and more available is molecular genetics, and is now available in many laboratories. And also the cost to do this analysis has come down significantly. So the classical approach to do a laboratory diagnosis in a child with is suspected of an inborn error of metabolism is to do metabolite analysis in different body fluids like blood, CSF, urine. And if there are some anomalies, then enzyme testing or functional studies in, for example, fibroblasts were done. And then the diagnosis was further confirmed by molecular genetics. Nowadays, in the omics era, we have facilities who do DNA sequencing or exome or genome sequencing. And as I mentioned, these analyses are now much cheaper than they used to be and more widely available. So you could also go straight for molecular genetics analysis and skip the other functional tests. And these are shown on the left side. So if there's patient with very suggestive signs and symptoms in the presence of a good biomarker, do metabolite analysis first, followed by enzyme activity and or Sanger or exome sequencing. For example, in alkaptonuria, which I already mentioned, homodenticic acid in urine is elevated, and this is a specific and sensitive biomarker. So the enzyme defect is at the level of homodenticic acid deoxygenase, which is shown by the red bar, and homodenticic acid accumulates and leads also to this discoloration of the urine if it's exposed to light, and also of the eye, as I have shown, and the cartilage and bones. So these patients develop cartilage and bone problems, and sometimes they have to get hip replacement at a young age. So I mentioned metabolites, biomarkers are the most common ways to make a laboratory diagnosis. And you could also do enzymatic testing, for example, in PKU, phenylalanine hydroxylase deficiency, where we have elevated levels of phenylalanine and low levels of tyrosine. And in this disease, phenylalanine is a reliable biomarker for PKU, and you can easily rely on this biomarker in blood. So the phenylalanine hydroxylase depends on the cofactor BH4 tetrahydrobiopterin, and there are defects of this tetrahydrobiopterin synthesis and recycling, and so these patients do not have enough BH4. Thus, phenylalanine hydroxylase cannot work, and they have elevated phenylalanine despite a normal phenylalanine hydroxylase enzyme. There are several subtypes in PKU. The classical PKU is due to the phenylalanine hydroxylase deficiency. That's the most common one. Then you have the so-called atypical PKU, where it's a defect of BH4 tetrahydrobiopterin metabolism. And then you have the BH4 sensitive form of PKU, where high levels of BH4 can stabilize the defective phenylalanine hydroxylase and lead to an increased activity. To differentiate between these three forms, BH4 sensitivity testing is done in every child with elevated phenylalanine levels in blood. So metabolites can be analyzed in body fluids like blood, urine, cerebrospinal fluid. For example, neurotransmitters can only be analyzed in cerebrospinal fluid. They can be analyzed in cultured skin fibroblasts, and in some disorders, there's intracellular accumulation. And in these diseases, to do the diagnostic workup, you have to do specific preparation of samples before testing, for example, in cystinosis, which is also storage disorder. So in this lysosomal storage disorder, the cysteine transporter is deficient in the lysosomal membrane, leading to elevated cysteine levels in the lysosome. And you have to do some pre-analytical procedures to isolate first leukocytes. You can see it on the right-hand panel. That's after centrifugation of the blood sample, and you see this layer, this leukocyte layer, and this is then used for further analysis. It's centrifuged, you get isolated leukocytes, and these are then analyzed for cysteine levels. You can do enzymatic testing both as primary test and as confirmatory testing. Now come to another lysosomal storage disorder. This is morbus Fabry, which is inherited as an X-linked disorder. The enzyme deficiency is shown here. And as it's an X-linked disorder, the women which have two X chromosomes can have variable symptoms. So if the intact X chromosome is inactivated during the Lyon process, then there's a severe cause of the disease. But if the defective X chromosome is inactivated, then you have a quite benign disease. And in males who have only one X chromosome, they have mostly a severe disorder. The enzyme which is affected is alpha-galactosidase A, which degrades GB3, globotriaosylceramide, which is shown on this scheme, to lactosylceramide and galactose. And if this enzyme does not work, then several compounds accumulate. This is not a one enzyme, one substrate disease, which makes it a bit complicated with respect to diagnosing this disorder. So we have accumulation of globotriaosylceramide, which is accumulated in the tissues because it's hydrophobic. And on the other hand, there's hydrophilic lyso-GB3, which can be found in blood and can be used to make the diagnosis and also to follow up the patients under therapy. So, for example, this is a cardiac capillary vessel, and you can see the storage phenomena before and under therapy. So there's a decrease in the storage of this compound under therapy. The routine biomarker is lyso-GB3, which is hydrophilic and can be found in blood. The GB3 itself is hydrophobic and can only be found in tissues. But as this is not a one enzyme, one substrate disease, it's less reliable. It's not as reliable as, for example, phenylalanine PKU patients. Even though that's a single enzyme deficiency in morbus Fabry, female patients often have slightly reduced or low alpha-galactosidase activity because of this X chromosomal inactivation. And enzymatic testing in females is not reliable, so it can be low normal even if the female is affected. And in females, genetic testing is always required. Then you could do molecular genetics. This last point in this slide, both primary and confirmatory tests can be done. In some disorders, no biomarkers are available, and then you have to go straight for molecular genetics. You could do imaging, for example, spectroscopy of the brain. Here you can see the lactate peak, which is suspicious for a disorder in oxidative phosphorylation or mitochondrial disorder. And here you can also see on the MRI of a child or a young man with mitochondrial disorder. You can see these changes in the cortex and white matter and also in the basal ganglia. This is a young man with Miller syndrome. And this is a picture from a patient with Lee disease. So the neuro imaging people, the neuroradiologists, they can do these scans, and they find this typical pattern, and this is quite characteristic of energy depletion in the brain. And also this can be supplemented with or by spectroscopy. And also here you can see white matter changes in a patient. Another option is to do histology or electron microscopy, which is shown here. The different forms of staining. On the lower right-hand panel, you have electron microscopy with the abnormal mitochondria. And on the left-hand lower panel, there are the typical ragged red fibers or R fibers with Komori trichome staining. So in mitochondrial disorders, the laboratory diagnostics do not yield always pathological findings. These are multi-organ disorders with tissue specificity. Metabolites are diluted in the blood fluids, and the parameters depend also on energy demand. And therefore, to make a diagnosis of mitochondrial disorder, mostly genetic testing is required. Molecular genetics can be done both as primary and confirmatory test. In some disorders, there are no biomarkers available, as I mentioned, for example, in mitochondrial disorders, respiratory chain defects, and you have to rely on genetic testing. So why is functional testing still important in the era of genomics? Whole exome sequencing or whole genome sequencing usually generates a list of genes, and for interpretation of any new exonic sequence variant, the in vitro prediction programs are not always reliable, and so you don't know if this genetic variant is really of importance and pathophysiologically relevant, and therefore it makes sense to do some functional testing in addition to see if this variant is really disease causing or it's a variant which is insignificant. So yes, that's what I already mentioned, that you can do additional functional testing, and whole exome sequencing or whole genome sequencing may not identify the right gene. And also the two mutations which you find in genetic testing may be on one allele, so maybe monoallelic, not biallelic. And therefore you should also try to do triome sequencing, so you should also have a look at the genes of the parents. So coming to the laboratory diagnosis in the new omics era and the importance of functional testing, on the right-hand side, you can see the testing during in the omics era, and on the left-hand side, the classical testing with metabolite analysis first and enzymology and genetics. But nowadays you could go straight for whole exome sequencing or whole genome sequencing. And this may yield a variant of unknown significance in known inborn error of metabolism gene. And then functional studies are important to see if this variant of unknown significance is genetically significant or not. If you don't find a mutation in whole exome sequencing or whole genome sequencing, and you have still a strong clinical suspicion, it may also make sense to do biochemical studies. If you find a novel gene, which is unknown, then it also makes sense to do biochemical studies to see if this mutation affects biochemical pathways. If you find a known mutation, then it's not absolutely necessary to do biochemical studies. So these are the different pathways. And well, we are in Hanover a member of the European Reference Network for Inborn Errors of Metabolism, so-called METAP-ERN. In Europe, there are about 60 or 70 different reference networks for different groups of disorders. And we are also accredited training center for pediatric metabolic medicine, accredited by the Society for Study of Inborn Errors of Metabolism, SSIEM. And well, you are more than welcome to contact me on my via my email, or alternatively, it's also possible that some of your students come for electives to our department and also get some training. So I now close with the famous German writer and poet and scientist Goethe, and I look forward to your questions and answers and comments.
Thank you, sir, for that excellent presentation on the overview of the metabolic disorders and how to investigate, especially in the era of genomic era. So I think some of you may have some questions. If you are now wants to ask, you can directly ask that, or you can put it into the chat box so that we can discuss that one by one. Both are acceptable. But without wasting much time, I thought we will have the already late. We will have one case presentation, which is from our hospital, because I have taken a case which we don't have result of the exome so far, because we are having a lot of very interesting and rare case of metabolic disorders, but everywhere exome has been done, which printed the final diagnosis, which I thought there is not much interest in the diagnosis. So it is a recent case, 2 weeks back, admitted in the ICU. And unfortunately, we are not able to save the child. The child was very sick, and we have got some information. Along with that, we have sent the exome. We are waiting for the result of the exome. And Dr. Anandalakshmi will present that case. And if you have got any doubt, please put it into the chat box, so that after that case presentation, we can discuss both regarding the case as well as the general doubts regarding the evaluation of metabolic disorders. Anandalakshmi, I think, can you share the slides? Anandalakshmi? Anandalakshmi? So anybody having any doubts to be asked? Please.
Sir, I'm not able to share, sir.
You are now co-host.
She has been made a co-host, sir.
Why? Anandalakshmi is co-host now. So can I share?
I've made all participants to share screen, so she should be able to share now.
Once again.
Sir, can you see now? Can you see now?
Yes, it's visible.
Yes.
Okay, sir. Good evening, all. I'm Dr. Anandalakshmi, Junior Resident at Department of Pediatrics, SAT Hospital. Today, I am presenting the case of a 5-month-old male child, first child of non-consanguineous marriage, developmentally normal, immunized for age, with antenatal history of maternal UTI in 3rd trimester, with no other maternal comorbidities. He was a term AGA 3.16 kg baby with weak cry soon after birth. He had seizures with hypoglycemia and metabolic acidosis on postnatal day 1. The NSG short bilateral grade 1 GM bleed. He had NICU stay for 5 days and was started on serapeptoin. The antiepileptic drug was stopped at 2.5 months of age, since child was completely well afterwards with normal EEG and NSG. Now he presented with complaints of fever, noisy breathing, respiratory distress, and poor feeding for 3 days. He was exclusively breastfed. At admission, the child had mild respiratory distress, minimal facial puffiness, and pedal edema. The weight was between 0 and -1 standard deviation, length between 0 and +1 standard deviation, with normal head circumference. On examination, the child had hepatomegaly with liver span of 11 centimeter. There was no obvious facial dysmorphism, and admission, the GRBS was low with negative urine and blood ketone bodies. Course in the hospital. The initial hypoglycemia was managed with IV fluid and later started on oral feeds. The investigations revealed anemia and transaminitis. The total count was normal and CRP was slightly positive, and he was started on injection ceftriaxone and other supportive measures. The CSF study was normal. Child had one more episode of hypoglycemia with negative urine and blood ketones, and he had associated fever. On the day 5 of illness, there was worsening of the respiratory distress and child had poor sensorium and was shifted to PICU. There, he had rapidly worsening hyperbilirubinemia, transaminitis, anemia, and low serum albumin. He had deranged coagulation profile, and child was having generalized edema with gross ascites. The chest X-ray showed severe pneumonia with pleural effusion, and the blood gas showed metabolic acidosis with respiratory acidosis with elevated lactate. Course in PICU. He was initially kept on nasal CPAP, later intubated due to high NIV pressure settings and FiO2 requirement. Supportive care including TRBC and FFP transfusion, albumin infusion, NAC infusion, and ascitic tapping was done. Thiamine, carnitine, coenzyme Q, riboflavin, and pyridoxine were added, suspecting IEM. Antibiotics upgraded, suspecting worsened pneumonia and sepsis. The chest X-ray, repeat chest X-ray showed worsening pneumonia with severe ARDS. These are the investigations. The blood routine shows anemia and falling platelet levels, gradually worsening RFT and rapidly worsening LFT. And the blood gases showed severe metabolic acidosis and respiratory acidosis with elevated lactate levels. On further workup, he was negative for infections including dengue virus, HSV, and hepatitis viruses. He had anemia and thrombocytopenia. CRP was positive at admission, later negative. Serum procalcitonin was within normal limit. The blood, CSF, and ascitic fluid cultures were negative. The ascitic fluid was exudative in nature. USG abdomen showed hepatosplenomegaly and bilaterally mildly hyperechoic kidneys. Serum ammonia was normal. Serum CPK elevated with high serum triglyceride and LDH. The nasopharyngeal swab was positive for rhinovirus. CT abdomen showed moderate hepatomegaly with fatty infiltrates, ascites, subcutaneous and soft tissue edema, mnemonic consolidation of bilateral lines. The urine reducing substances was positive and the TMS GCMS came negative. Over the 7-day stay in PICU, child went into acute hepatic failure, acute renal failure, severe fluid overload, florid ARDS, severe metabolic acidosis and respiratory acidosis, and significant capillary leak with gross edema, decompensated shock, and finally succumbed to death. Summary of the case: 5 months old developmentally normal child born out of non-consanguineous marriage with history of symptomatic hypoglycemia on postnatal day 1, now with respiratory infection and hypoglycemia, with negative urine and ketone bodies. On examination, hepatomegaly plus. Blood shows severe metabolic and respiratory acidosis with elevated lactate levels, urine reducing substances positive, TMS and GCMS negative, and the child expired due to acute liver failure, acute renal failure, severe capillary leak over a period of 2 weeks. So the differential diagnosis I thought were glycogen storage disorder with secondary sepsis, mitochondrial disorder, fatty acid oxidation defects. Thank you.
In this case, even though she has presented as from the birth onwards, the case came to our setup only at the time of ICU. Before that, child was in the another medical college in the middle of the Travancore, some other area, and they were investigating for the possible glycogen storage disease or fatty acid oxidation disorder. But suddenly he developed a very severe form of, what you can say, altered sensorium, severe hypoglycemia, and went into shock type and referred in ambulance to the pediatric ICU. So when child came to us itself, child had a severe hepatomegaly, severe transaminitis, early hepatic failure, and severe edema. Severe edema means it's just like a severe capillary leak. So our primary diagnosis was a metabolic disorder with some infection which causes the primary leak, or some metabolic disorder which causes the leak. And we have thought broadly these 3 groups because hepatomegaly is there, hypoglycemia is there, so glycogen storage disorder, but so many things cannot be explained purely on glycogen storage disorder. So there should be some infection. But mitochondrial disorder is possible because transaminitis, hepatomegaly, hypoglycemia, as well as CPK elevation, mitochondrial disorder is possible, but he doesn't have any developmental delay or failure to thrive or MRI brain, we were not able to do it. And fatty acid oxidation disorder, because primarily he is an absolutely normal child with the hypoglycemia, hepatomegaly, and no ketone bodies. But later he developed ketone bodies, probably child will be sick. And but some of the things like elevated CPK, other things, not easily explainable. So we were not able to do it. So your thought in these type of cases where you will get in the last time with some sickness, how to go about?
And what about succinylacetone? It was normal?
Acetone.
Succinylacetone.
Succinylacetone in TMS, they have not identified, but there is no specific test for succinylacetone was not done.
So it could, from the clinical symptoms, could also be hepatorenal tyrosinemia type 1.
Yes. But the general TMS, sometimes it may pick it up, but it has not shown. But usually in suspected case of hepatorenal tyrosinemia, we will specifically do urine succinylacetone. That has not been done. We have done TMS and GCMS as a general screening test only. Specific test for succinylacetone was not done.
And well, if TMS was normal, then deficiency of long-chain fatty acids oxidation is also unlikely.
Very unlikely, very unlikely.
You may not pick up all the CPS2 forms in dried blood, but also it's not very likely that it's a CPS type 2.
And what about glutaric aciduria type? Rice syndrome like presentation, one type glutaric aciduria will present. That is possible.
in type 3, we have seen cases like this with extreme hepatosplenomegaly, and well, the hypoketonuria and hypoketonemia would be rather typical for glycogen storage disease type 1.
Yes.
But such acute liver failure, I think, is not that common in glycogen storage disorder type 1, but
Correct.
we've seen in glycogen storage disease type 3. And well, in mitochondrial disorders, you typically have elevated ketone bodies, but well, this is also, as mitochondrial disorders are so variable, it's not a constant finding, but so it cannot be excluded at this time.
Because urine ketone bodies for others also always will produce sometimes confusion, because even in a MCAT, classical fatty acid oxidation disorder, where we're not expecting a urine ketone bodies, when they present in the severe shock-like situations, sometimes urine ketone bodies may be positive. Similarly, in urine ketone bodies, when it has to be presented, in some situation, very rarely it may be negative also. So sometimes it will produce some confusion in classifying the disorders. Anybody wants to ask something regarding this case or general also? Because we had a detailed talk on the evaluation. Any of the postgraduates or any consultants? Any questions? Chat box, or you can directly also ask. Sharon?
Dr. Shankar, may I ask a question?
Yes, sure.
I am Dr. Geeta from Pathanamthitta.
Sure, Geeta.
Okay. Thank you, sir, for that very descriptive class. Long time I've been hearing this. Thank you very much, sir. Because this child had a newborn hypoglycemia, do you evaluate children for IEM if they have got a newborn hypoglycemia? Because the child was on anti-seizure drugs and all for a long period, no? Should we do? Because if we have got some cause, like say infant of a diabetic mother or SGA baby, then maybe it's not an issue. But in this child, because the child had seizure and the child was on till 2.5 months, they were on anti-seizure drugs and all. Were they evaluated for IEM? Or should you, should we as a policy evaluate? That's what I wanted to ask.
Sir, Ita is asking how important in a newborn, non-diabetic mother, normal birth weight, he is developing 1 or 2 episodes of hypoglycemia. How important to do the IEM screening?
Yes, well, if you can't find any cause for hypoglycemia, then you should do also metabolic workup, because many of the metabolic disorders go with hypoglycemia. But of course, if you have an obvious cause, then you don't need it. But I would go, so if there's no diabetes in the pregnancy, then I would also be prone to do some metabolic screening.
Thank you, sir.
There's a question on how useful is testing urine for reducing substance. How practical or how useful in the practice?
Well, I think it's quite useful. In the classical inborn errors of metabolism, you always find abnormal metabolite pattern, but in some milder forms, it's not always pathological. But you should, of course, do it in every child who's suspected of an inborn error of metabolism, because it's quite easy to get urine.
Any precautions in transporting or storing urine for testing for reducing substance? Same continuity question they have asked.
Yes, so the chance is that there's bacterial contamination, and so you sometimes people, some labs recommend to give some preservatives, and we don't do it. So we asked for the immediate sending of the urine samples if they have to be stored in the hospital because it's a weekend. Then they should be either frozen or stored in the fridge.
So metabolic disorders is actually, it's not rare in our part also. We are having, sir has shown a lot of metabolic disorders. Almost every metabolic disorders, at least we are having 1 or 2 cases, like CPT1 deficiency, CPT2 deficiency, translocase deficiency. Then MSUD is one of the commonest conditions we see in our area. Glutaric aciduria is another condition which is seen in our southern part of India. Then various forms of lysosomal storage disorders. All these type of metabolic disorders are not at all rare in our part. So always keep in mind that metabolic disorders has to be considered in the differential diagnosis of in suspected case, then has to be properly evaluated. If there is no more questions, I thank sir for giving an excellent talk on how to investigate in the era of genomics for a metabolic disorder. Similarly, Ananda Lakshmi, my resident, to present the case beautifully in 10 minutes. She has presented a real issue of a metabolic disorder, which we practically see. This patient will come in the very sick situation, lot of metabolic abnormalities. We know it is metabolic disease, but most of the time, some of the time, it is very difficult to clinch at that time, because if some more time we get, it may be easier. But in a situation where patient is already in a situation of ICU, so many abnormalities will be there, very difficult to clinch at that time. And finally, I am very much sure, definitely exome will give the diagnosis, but that can be used for genetic counseling and next baby. Definitely we are using it also. And if there is no doubt, thank you and congratulations, Ananda Lakshmi, for a very good presentation. Thank you, sir, for the excellent deliberation. Thank you, Jijo and team, Pathanamthitta, for giving me the opportunity to chair the very good session in the a little bit late, but I think since we are having so many PGs and consultants too here. Over to Arun, Jijo and Goldie.
Thank you.
Thank you, sir. I would like to invite Dr. Goldie Udayan, the Secretary of IAP Pathanamthitta, to the vote of thanks and to wind up the meeting. Over to you, Dr. Goldie.
Thank you, Jijo. It was a wonderful session from Dr. Anil Martin Das. Thank you, sir, so much for being with us this evening and giving us an elaborate talk on AEM. Thank you so much for your talk. And I thank Shankar sir. Shankar sir, it was a great evening with you. Thank you so much, sir, for giving us your time and spending your knowledge with us. And I thank our pediatric HOD believers, Dr. Jijo, for organizing this meeting. And I thank all the participants, PGs, everyone for spending this much time. And it's almost 10:30. Thank you so much for an academic piece. Thank you so much.
Thank you, Goldie. With this words, we'll be concluding the meeting for today. We're hoping to meet everyone for the next meeting. Thank you for your patient listening. Good night. Thank you.
Yes. Good night.
Good night. Good night all.